The lecture you are about to see is part of our annual Alan Edwards Psychology Lecture Series. Professor Edwards was affiliated with the Department of Psychology for half a century until his death in 1994. He was an outstanding teacher, researcher, and writer who introduced new statistical techniques that are credited with changing the way modern psychological research is conducted. Alan also permanently enhanced the intellectual climate at UW Psychology by endowing the Alan Edwards Lectureship, which since 1999 has brought in an impressive list of renowned psychologists to the UW campus to interact with faculty and students. The lecture you're about to watch is one of a pair given back-to-back that matched a UW psychology professor with a visiting researcher to talk about a topic of great public and scientific interest.
Good evening. My name is Sherry Mizumori, and I'm chair of the psychology department here at the University of Washington. Now, I'd like to welcome you to the 6th annual Alan Edwards series that we put on. And the topic of this year's lecture series is diversity, culture, and behavior. Now, before I talk about more details about the speakers that we'll be having, what I'd like to do is just take a few minutes to talk about how it is that these lectures came about in the first place. Now, these public lectures are made possible by a generous endowment by one of the former professors in our department, Alan Edwards. He spent 50 years of his career in our department, and he passed away in the mid-1990s. Now, at the time that he passed away, then his family made a very generous endowment so that we can bring in world-class lecturers through the psychology department and also to the university campus at large. Now, Alan Edwards is probably most well known in the psychology field for the fact that he brought statistical methods, rigorous statistical methods, to the science of psychology. And his textbooks have really become the gold standard for a number of different kinds of areas within psychology, and they still are used today. And so clearly he has made a name for himself there, but in addition, because of this lecture series that he's allowed us to have, he's now, his name continues to be discussed in a different light throughout the department. Okay. And we're very grateful for the family's donation. Now, the Edwards family contribution to the psychology department really exemplifies what can be accomplished with support from community folks such as many of you here today. I know that a number of you have made contributions to our department, and given that our tough economic times these days, I just wanted to take this opportunity to say thank you, and that it really is making a big difference. Now, the psychology department seeks to take advantage of the unique collection of world-class researchers and instructors by facilitating interactions between traditional disciplinary areas within psychology, such as the cognitive psychology, developmental psychology, social psychology, and so on. We aim to foster a dynamic and vibrant synergy that leads to innovative solutions to the largest of societal problems. Now, this year's focus on diversity, culture, and behavior then exemplifies the department's unique type of interdisciplinary and collaborative and comprehensive research programs that use tools of behavioral assessment, neuroscience methods, social, clinical, and developmental theories to advance our understanding of the influence of diverse and cultural perspectives on psychological well-being and decision-making. Now, so you'll see that such a comprehensive understanding really is essential if we're to maximize individual as well as societal productivity. Now, tonight we focus on research, again, aimed at understanding issues in mental health from a global perspective, another multicultural perspective. Now I'd like to introduce our first speaker, Dr. Craig Van Dyke. Now, Dr. Van Dyke is a UW alum in that he spent his undergraduate years here, and he also did his medical training here at the University of Washington. Now, following a medical internship at Cornell University Hospital Systems in New York City, he was a medical officer on a ballistic missile submarine. He then completed his psychiatric training at Yale University and was on the faculty there for several years before moving to University of California in San Francisco, and also the San Francisco VA Medical Center. His research is focused on the effects of cocaine in humans and on neuroimaging in patients with cognitive dysfunctions. Now, as a clinician, he was for many years a consultation liaison psychiatrist taking care of medical and surgical patients with emotional problems. He became then Chief of Psychiatric Services at the San Francisco VA Medical Center, and then he became chair of the UCSF Department of Psychiatry, of which he was chair until 2008. Now, Dr. Van Dyke currently is professor and director of the Global Mental Health Program in the Department of Psychiatry and Global Health Services at UCSF. He has developed working relationships with the Shanghai Mental Health Center, the Department of Psychiatry, and the School of Medicine at Afad University for Women in Omdurman, Sudan, and Sichuan University in Chengdu, China. He also is a member of the University of California team that responded to the devastating Sichuan earthquake in May of 2008. Now, along with Dr. Mandel, he directs a global mental health scholars program that provides clinical research training for scientists from low and middle income countries. And then during the 2008 and 2009, he was a special advisor to the director of the National Institutes of Mental Health on global mental health. Now, in recognition for then his lifetime achievements, the Regents of the University of California in 2007 awarded Dr. Van Dyke a J. Elliott Royer Award for his significant contributions to the advancement of psychiatry. We are really quite fortunate to have such a distinguished guest lecturer, and also to know that he's one of our own. Welcome.
Thank you very much. It's a real pleasure to be back in Seattle. I had a wonderful 8 years here. What was left out of the introduction is I started off to be an oceanographer and discovered as I was heading out in Lake Washington that I was getting a little nauseous. And by the time I hit the Pacific Ocean, I said, I think I'm going to have to change careers. So other than those memories, I have very, very fond memories of Seattle and my time here. And my task today is to talk about global mental health, the why now. Dr. Simone is going to talk about the how now. I will just mention an occasional sort of how now issue, but mostly it's going to be on why now. And the issues around why now are really three in my view. One is the humanitarian imperative, and that is if you think of all human life as being of equal value, and that as part of that, each and every person on the earth is entitled to good health care, that this is a big issue because of the great inequities in health care between countries, between high-income countries and low- and middle-income countries, and also inequities within each country. And if you think of the U.S., we have tremendous inequities in health care in the U.S., and I'll talk about that ever so briefly. But nowhere, I think, are the inequities greater than in mental health delivery. And it's not only that 90% of people in low and middle income countries don't have care or even have access to care if they wanted to go, but these patients, these individuals are often subjected to human rights issues, abuses of one kind, being incarcerated for long periods of time without a clinical justification, receiving ECT without anesthesia, and in many places they're chained to trees, or even when they're in these mental institutions, people have been chained or put in cages. And so I think this is unlike most other medical conditions and is unique or somewhat unique to psychiatric patients. This also has great relevance to the U.S. Because, as I mentioned, we have tremendous inequities. And just to mention a couple that are relevant to us, that, I've talked about low and middle income countries, but the U.S. in a sense has low and middle income counties and has low and middle income parts of cities. And so many of these health issues that you see in low and middle income countries are here in the U.S. And just to mention some of the problems, that here we are, one of the wealthiest nations in the world, yet 43 million American citizens are on food stamps. 21% of children in the U.S. are living below the poverty line. So of the 25 most developed countries in the world, the U.S. has the highest rate of children living in below the poverty line. And then the final issue, I think, is that global mental health has really energized so many people in the world, and that it's energized the youth in this country, young students, young faculty members. It's energized people in low and middle income countries. And we have a lot to learn from low and middle income countries. You know, Nigel Crisp, who was the director of the National Health Service in England, said that for years, high-income countries exported ideas to low and middle income countries and imported physicians from these countries, and that we ought to turn that upside down, and America ought to be, or high-income countries ought to be exporting doctors to low and middle income countries, and more importantly, importing their ideas. And I think some of the demand characteristics of low and middle income countries, where they don't really have any choice, they have to come up with very creative ideas about how to serve their population in ways that we don't, are some of the things that we can learn from them, and Dr. Simoni will address those. So today I'm going to talk about the world in a north-south divide, not an east-west divide. I'm going to talk about inequities, social determinants, mental illness, stigma and myths, the global burden of mental disorders, and then I'm going to talk about two countries, China, which is a middle-income country, and the Sudan, which is a low-income country, in part because I think they exemplify the kinds of issues that are going on in these countries with various income resources, and it just happens that I've worked in both of those. And then I'm just going to end on a kind of transition note on the interconnected world and some of the potential that's out there, not only in terms of the young, but in terms of technology and how this might address some of these issues. So this is the International Monetary Fund sort of distribution of wealth in the world. And the map shows in blue the countries that are above the $10,500 average GDP per capita of the world. Now this is, the PPP stands for purchasing power parity, and it's an attempt by the IMF to equate purchasing power, because some countries distort their exchange rate, so just doing an equivalent exchange rate gives you distorted data. So this is an attempt to sort of divide the world in the blue into the high income countries and whatever orange color that is into the low and middle income countries. And as you can see, this is really a north-south division with some exceptions obviously in the south. Now, this is a World Health Organization slide, and on the horizontal axis is the percent of the total global workforce. This graph is not about mental health per se, it's about total workforce in the world, and on the vertical axis is the percentage of the global burden of disease. And I'll explain the burden of disease a bit more, but functionally it's really the total of premature deaths as well as individuals living and having functional disability. And the size of the orange circles represents the dollars expended. So on the right, the Americas, which really represents the US and Canada, as you can see, it has roughly 37% of the global workforce, global health workforce. It has roughly 10% of the burden of disease. It has about 5% of the world's population, and we spend roughly 50% of healthcare dollars for the entire world. Now, this represents roughly $2.5 trillion out of $5.5 trillion. In terms of the mental health issues, in the US, I don't know about Canada, but in the US, we're spending about $225 to $250 billion a year on mental health issues. And the US has somewhere between 400 and 500,000 mental health professionals. So you can see we're extremely well-resourced, much more resourced than our population or the burden of disease would have us indicate. Now, if you go to the upper left, to Africa, if I can use this, Africa has about 11% of the world's population. It has about 24% of the burden of disease. It has about 3% of the world's health workforce, and it expends about 1% of the health dollars in the world. And so for mental health, it's hard to estimate, but I would say it's probably on the order of somewhere between $2 and $4 billion a year are spent on mental health issues. And there's probably 10,000 plus or minus a couple of thousand of mental health workers in Africa. So in a sense, you can see the world is upside down around how the resources are distributed, and in terms of the countries with the smaller burden of diseases or areas having much more in the way of dollars and workforce. And just to point out the issues in America, that on most measures of health care, the U.S. is somewhere between 37th and 42nd in the world in terms of the quality of care delivered here. So in another level, we're not getting a very good value for our money. And we're probably got a somewhat unaffordable health system at the moment. This is, again, a north-south distribution. I couldn't find one for psychology. This is for psychiatry. And you can see the dark blue is where most of the psychiatrists are in the world. I think it's important to point out, however, that countries are colored all one color. It really is not trying to show an equal distribution of psychiatrists through these. So if you go to the southern tip of South America here, to Tierra del Fuego, I doubt if there's any psychiatrists there. I don't know. I think this is all part of Argentina, and most of this represents psychoanalysts in Buenos Aires. Similarly, if you go to the polar regions of Canada, Alaska, or the USSR, I'm sure there are not a lot of psychiatrists up there, so this is a somewhat distorted issue. But this has relevance, I'm sure, in Washington. I know it has in California, where I am, in the Bay Area. You don't have to go very far from San Francisco to be in counties that essentially are devoid of mental health care. And it's also an issue, I know, in Northern California around primary care, where there's very few primary care physicians. Many of the physicians who are there are in their 60s and 70s. Nobody young is coming in, and there's a real crisis about how are you going to deliver primary care there. And if part of the solution is delivering mental health care through primary care, that's going to be difficult even in America. So what about the global mental health inequities? And I think one of the important things to remember throughout this is that our illnesses are widely distributed throughout the world. Unlike many infectious diseases or tropical medicine that were restricted to certain geographic regions, mental illness, by and large, is equally distributed around the world. And there are some variations country by country, but that is not an issue. And so, in a sense, figuring out something around how to deliver mental health services or better approaches, if we can figure that out in a lower middle income country, it can be applied to a high income country, potentially, or vice versa. Some of these others I'm going to talk about in a bit more detail, the social determinants, stigma, but I did want to point out around the chronic diseases of the young. You know, a lot of attention has gone to infectious diseases, AIDS, malaria, and TB, and understandably so. And I think particularly some of those infectious diseases, not only malaria, but some of the diarrheal GI infections, have gotten a lot of attention because they kill very young people. And it's understandable that that has a big appeal in terms of people supporting that, and it's very, very understandable. Now there's more and more interest around chronic diseases, heart disease, lung disease, cancer, diabetes, et cetera. And with most of those are diseases of middle age or older. Mental illness is really a chronic diseases of the young. Most of these illnesses have their onset in the teenage years to early adulthood, and they tend to be lifelong illnesses, either chronic illnesses or recurrent illnesses. And I think over the next 10 years, there will be more and more awareness of that as an issue and more support for these conditions and their treatment. The other thing is we now have a number of cost-effective treatments. We don't have bed nets for malaria equivalents, and we don't have vaccines, but we do have treatments that are on the par in terms of cost effectiveness with other chronic medical conditions. The problem is in many countries, in low and middle income countries, in parts of the US, many people go untreated. In America, it's probably 30 to 40% go untreated for a variety of reasons, which we can talk about. And in much of the rest of the world, it goes untreated because simply resources are not available to them and they can't access treatment. Now, many medical conditions have social determinants or behavioral determinants, smoking cigarettes and all the problems of that. And in most of our illnesses, we talk about a gene-environment interaction. The notion is that all of us carry various genetic vulnerabilities that don't manifest themselves unless we run into a particular environmental situation that brings the disease forth. And one of the big social determinants of mental illness is poverty. And we know that if you go to impoverished areas, the rates of almost all mental illnesses are much higher than in areas that aren't impoverished. But we really don't know how this works. We know, for example, that if you develop a serious mental illness, you're likely to become much less productive, can't go to work, can't go to school, can't earn a living, et cetera, and that your socioeconomic status will drop. What we really don't know is if you take an impoverished area and somehow raise its economic basis, whether mental illness will go down. We have very little. We have one study that I'm aware of, maybe other people here know, and that was a study actually done in America, in North Carolina, on a Native American reservation where they brought in a casino. And the income of the tribal members went way up, in part because they got the profits of the casino, and two, because they were preferentially hired in the casino. So families suddenly went from below the poverty line to well above the poverty line. And in fact, in their teenage children, some of the mental illness rates went down, particularly in kind of behavioral disorders and so-called conduct disorder, which is kind of antisocial behavior, and also in oppositional defiant behavior. Many people might define that as the normal part of being a teenager, but kind of the rebellious teenager. And they went down, actually significantly. They went down to the rates that are typical for a non-impoverished population. And the mediating factor, they thought in this study, was increased parental monitoring of teenage activity. And so good parenting might have been one of the mediators for this. Insecurity, food insecurity is a big issue in the world. There's a lot of evidence that if you don't know where your next meal is coming from, you have much higher rates of anxiety and depression. We have a lot of food insecurity in the US. It takes different forms, but it's not an issue unknown to our population. And many of the other issues, gender inequality, the minimal education, low literacy, et cetera, in part is related to gender-based issues. And I'm not going to belabor this except to kind of tell a story that I heard not too long ago from a Nepali medical student at Yale University who's going into psychiatry and was coming on the interview trail to apply for residency programs. And this is a man from a remote mountain village in Nepal, clearly a very talented man, who started his own, with a few other Nepali physicians in America, started his own NGO to support a small hospital in his hometown. And he told me that the #1 cause of death in women in Nepal between about age 16 or 17 and 50 was suicide. And that most of this is related to alcohol-fueled domestic violence. And it's gotten so bad that suicides there in women are now sort of socially supported or condoned, and the feeling is that the woman is in a more peaceful place. And so I think it's kind of captures so many of these issues that are related to the way women are treated in the world. The only other one I'll mention, and that is the rapid social change. And we see that in countries where not only is there out-migration, but there's a lot of migration from the rural areas to the urban areas. Stigma, we've talked about this a lot. I'm sure most people have thoughts about that. I think a lot of people in this country, but in all countries, think the mentally ill are somehow morally weak or not very tough-minded. Stop thinking that way. There's a lot of sense of there are no effective treatments, and for a long time in medicine there weren't effective treatments, and in lots of the world, as I mentioned, there aren't access to care. And so between stigma and there's no effective treatment, it really affects who comes to care. If it is available, people don't want to come. A lot of people feel suicide is not a health problem, that it's a deeply personal, private matter, that it's not a social issue, it's not society's responsibility. If people want to kill themselves, they should be allowed to do so. And so I think that is a real stigma about this. And I can tell you, if you're a parent of a teenager who has a love loss and impulsively kills themselves, you don't feel that was not a social issue or a family issue. It's really a tragedy. And if you see families of people who've taken their own lives, it's the hardest death, I think, in a way to recover from, because there's so much anger and guilt, etc. In much of the world, I think stigma sort of dehumanizes patients with mental illness, and that's what allows people to violate their human rights. It distorts public policy. It distorts medical education. A lot of medical schools in low and middle income countries do not teach their medical students about mental illness, or if they do, it might be an hour lecture or go read these 2 pages and that's it. They don't get any real sense of what these are like or how to treat them or be exposed to these patients. And in many countries, mental health treatment is viewed as a luxury, and you're starting to see states in the United States cut back on mental health care as their budgets get worse and worse off. So even in this country, you had those issues. Here is the prevalence around the world. Some people might disagree with these, and if you add these up, it comes up to a big number. I would just mention that some of that is due to the fact that individuals may have more than one of these conditions simultaneously. Depression, anxiety, alcohol abuse commonly go together, and so these are not separate people here. Depressive disorder, for reasons I think we don't fully understand, is a very common disorder, but is essentially twice as common in women as in men. Personality disorder, a lot of people would disagree or think that this may not be a psychiatric diagnosis, or at least some of them aren't psychiatric, represent medical disorders, mental disorders. And I think others would say that schizophrenia and bipolar disorder might be twice this rate in much of the rest of the world. The one thing we know about mental disorders is that these people die younger. In high-income countries, it's probably 10 to 20 years. Some of this is related to taking their own life, but some of it's related to medical disorders, heart disease. It's said in America that almost 50% of all cigarettes are sold to the seriously mentally ill. Lots of these people just do not seek medical care, come in with a high white blood count, for an emergency room is found to be high, and then they're lost to follow-up, and it turns out they have leukemia. So that's not an uncommon issue. And is these personality disorders that I mentioned about whether that's a valid diagnosis, it seems to be related to a 4 times the rate of mortality rate compared to a healthy population. So there's some validity to it. Suicide, 10 to 20 million attempts a year. These are not without consequence. People injure themselves. A lot of that's permanent. They obviously cost health systems a lot of resources in dealing with it. It's estimated that there's 1 million people who do complete suicide attempts. It's probably a serious undercount. There's probably many more people do that than 1 million. Sometimes it's hard to figure out the intention of the individual, but obviously there are social, political, economic reasons for not calling it a suicide. Most of these individuals have psychiatric diagnosis. It's not just depression. Roughly 5% of patients with schizophrenia will take their life. A lot of impulsive suicides, particularly in China and in women, where there's a series of social stressors, people get upset, and then they ingest pesticide, and it's almost universally fatal. And China and India are the two countries in the world where approximately the same number of women take their lives each year as men. In most of the rest of the world, women make many more attempts, and men are more likely to complete suicide because of the means they use, gunshot, hanging, et cetera, which are almost universally fatal. But in a lot of these countries, it's not only pesticide, but self-immolation. And so women frequently self-immolate and die as a result of that. Suicides are more common in most countries than homicides. America, many people would say we're the homicide capital of the world. There are 20,000 homicides a year and 30,000 suicides. And in most years, in years where there aren't major genocides, there are more suicides than from armed conflict. So I mentioned the burden of disease. I'll go through this quickly. A lot of that was done here at the University of Washington. It's really, I think, been a major contribution to the field and gotten a lot of people energized. And it's really two things: the years lost of life lost. That is, if a child dies at age 1 and the average lifespan of that country is 50, that's in essence 49 years of total disability. And then plus the years lived with disability, and there have been various systems used to rank functional disability. And in 1990, this came out as the rank order of conditions that were contributed to the worldwide burden of disease. And the most, I think, surprising and I would say probably created a lot of disbelief in people was that major depression, that is not manic depressive illness, but unipolar depression, was the 4th leading cause of the burden of disease in the world. And I think a lot of people didn't believe it because there was a lot of questions about the measures for functional disability. But now there have been a number of replications of this using different methodologies, and this seems to be holding up. And in fact, a projection for 2020, and this projection is based in part on the economic status of the world population in a number of places improving, and so the sort of infectious diseases and perinatal deaths drop down, and ischemic heart disease and unipolar major depression move up. And in part, major depression moves up because more and more people are living to be old enough to be at risk for the onset of these conditions. And for 2030, HIV/AIDS is projected to be the #1 cause, and unipolar depression second. In high-income countries, it's projected in 2030 to be first, second in middle-income countries, and third in low-income countries. And if you look at it, some of these others, if you take road traffic accidents as a major cause, a lot of that has to do with alcohol abuse. So the burden of disease related to depression is the early age of onset, the high prevalence. It's a recurrent chronic course if untreated, and it's got high functional disability. And the ratings are somewhere between 35 and 65% disabled, depending on whether it's moderate or severe depression. And you can say, well, how can that be? Well, I can tell you that people with severe depression really are non-functional. I mean, they can't think, they can't get out of bed, they can't go to work, they can't go to school. I've had patients who are very successful businessmen who go into a major depression. They can't read the paper, they can't concentrate, they can't read a book, they can't go to a movie and pay attention to the movie. They are ruminating, they are so preoccupied with their problems that they're non-functional. The other issue about depression is it's co-occurring or comorbid, as we say, with many, many medical conditions. Probably somewhere between 25 and 50% of people with chronic medical conditions have depression that goes with it. And this obviously affects their ability to adhere to treatment. and the success of the treatment for their underlying medical condition. But for HIV, AIDS, and cardiovascular disease, it also seems to be a risk factor for getting it, and once you get it, you do worse. And one of the mediators for cardiovascular disease has to do probably with inactivity. Depressed people isolate or inactive and probably are at risk for getting heart disease as a result of that. So now I'm going to finish by talking about just a couple of examples. And I'm going to start with China, a middle-income country, and I would say an incredible naturalistic experiment in that here is a country that over the next 10 or 20 years is going to lift hundreds of millions of people out of poverty. And the effect on society and the effect on healthcare will be profound. And I'm going to start by an experience I had. Well, I can't see it on here. In Sichuan, in Chengdu, which is just to the right of Tibet. So Sichuan, can you all see that? Sichuan is a beautiful place. It's kind of the breadbasket of China. It has the pandas. And Chengdu, the capital of Sichuan, has 12 million people. And it's quite a lovely city. And so the first thing that was a big experiment in China is the one-child policy. So in terms of social determinants of mental health and how issues come up in a society that lead to certain places. So in the 1970s, China did some calculations and projections about their future population and came to the conclusion that by the year 2000, they were going to have 6 billion people. Now, in retrospect, their calculations were not right, but they had tried asking people to sort of delay having their first child and to spread out the interval between children, and that was not working. And so they imposed the one-child policy, which I'm sure you've all heard of. And I like this picture because it's a boy up there on the shoulder, which I think speaks to the preference for boys for male children in China and in much of the world. But it's led to a lot of social changes. If you think about it, there are not only no siblings, but there are no cousins. It's led to gender imbalance. It's led to what in China people call the 6 pairs of eyes focused on this one child. That is 2 sets of grandparents and the parents all zeroed in on the performance of this child, because not only is this carrying the legacy of the family, but this is the Social Security policy for the family, because there are no safety nets in China at this point around what do you do in retirement. You have your savings and you have your one child. And it's led to gender imbalance. Now this intersected with an event at 2/28, which is a weekday, on May 12th, 2008. And this was the Great Sichuan earthquake. And this was magnitude 7.9. It was 80 miles sort of slightly west and north of Chengdu. This lasted 80 seconds. I'm sure everybody in this room in Seattle has probably been in an earthquake, right? But not 80 seconds, right? But this was a major, major earthquake. The vertical movement was up to 9 to 10 meters. People there were talking about seeing the tips of mountains that were behind other mountains that they'd never been able to see before, et cetera. And there were many, many aftershocks. As you can see, there were over 60 in the 4 to 6.0 range, which is pretty dramatic. And I can tell you at the Sichuan University Medical School, medical students, this is 60 miles away from the epicenter. Students were jumping out of the building, and the dean kept coming to the medical students, say, whatever happens when the next quake, don't jump. And of course, the next quake would come and they'd jump, and they would have broken legs and pelvises and that sort of thing. So it was pretty dramatic. People lived in their cars for months. Even though they had homes, they were afraid to be in their homes. And this just sort of shows you the Loma Prieta one, which I was in. It lasted, 15 seconds? It seemed like 15 minutes. It kept going on and on and on. And some of the difference, obviously, is the magnitude of these earthquakes, but also a lot of it has to do with the construction And one of the issues in China was that there was poor construction, very little steel in the buildings to hold them together, and schools were particularly poorly constructed because there had been issues around corruption and not putting that steel in the building, et cetera, and this happened in the afternoon of a school day. So this is a picture I took. It's a lesson: if you live in an earthquake zone, don't live near a river or the ocean, because the soil is alluvial soil and liquefies, and you don't live through that. So there were 70,000 fatalities, 374,000 injured, 18,000 missing. Most of these were buried in huge landslides where literally half of a mountain fell off. And there were 18,000 children lost in this, many of them only children. And this is just an example of, the kind of issues people face. This person lived, but a lot of people lost their only child. And this school, this is also my picture, but which is very close to the epicenter, was isolated from rescue workers for weeks because these landslides had made the roads impossible. And these landslides, some of which I went through 4 weeks after the earthquake, were one of the scariest things I've ever done in my life, because the boulders the size of my house were coming down these mountainsides. And they couldn't get heavy equipment in there to rescue these kids. And so parents, listen to this, parents were talking to their children buried in this school for 3 or 4 days, and which point they eventually died. But can you imagine what that was like? It's, gives me the shudders just thinking about it. China, I think, did a remarkable job, much better than we did post-Katrina. They basically, within 2 years, rebuilt permanent housing for all these people. But this was a meeting I was at. This is the fellow in blue is a mayor. And the citizens were really giving it to him around where they were going to rebuild their house, who's going to pay for it, what sort of services there would be, et cetera. And I think what the Sichuan earthquake did was bring to China's attention, bring to the government's attention, the importance of mental health issues. I think trauma got their attention because China, up until then, I would say, and still lots of China, is a kind of, don't talk about any of your mental problems, it'll just make it worse. Don't seek help, that'll make it worse. Just forget about it, don't think about it, et cetera. But I think the government, the Ministry of Health, realized that this was an issue for which they didn't have an answer. And China is now, as a middle-income country, really gearing up its mental health services. And how many people have been to China? How many people have it on their travel plans? It's an amazing place in many ways in their ability to scale up services. And we were talking earlier today how, a few years ago they denied they had an HIV problem, then they realized it, then they realized they had a drug abuse problem, then they wanted to move to methadone maintenance, and suddenly they got thousands of methadone maintenance clinics. It's just incredible what they can do when they make up their mind. This is another social phenomenon. This is not my name for it. This is a sociologist in China talking about ant tribes and ant nests in China. And this has to do with China's graduating 6.5 million people a year from college, many of them trained in high-tech jobs, and they move to the cities. And of course, the only jobs available are manufacturing jobs, and they end up living in very difficult circumstances. And I think this probably got the most notoriety around the Foxconn situation, where there are a series of suicides. But in terms of a middle-income country, Foxconn did set up a kind of round-the-clock psychiatric counseling service, so they were able to develop industry-based services. So the next country I'm going to talk about is the Sudan. How many people have been to the Sudan? One. How many people have it on their travel plans? I think 3 or 4. So this is a very different situation. This is a country that's just below Egypt. It's geographically the largest country in Africa. It's got, Khartoum is there. I didn't realize why Khartoum was there, but Khartoum is there because that's where the Blue Nile meets the White Nile. It's also where the Arab world meets Black Africa and where the Islamic world meets Christian and animistic cultures. And Southern Sudan, as I think most of you know, has just recently voted to be a separate country, which, if everything holds, will go into effect, I think, in July. And the Southern Sudan has the oil, but Port Sudan, which is on the Red Sea, has the access to the rest of the world. And so there's a pipeline from Southern Sudan up to Port Sudan, and there's a refinery there, and it's all sent to China. I was invited there. This is just a picture driving down the street in downtown Khartoum, just to give you a sense of there's nothing green there. This is dust in the air. This is a difficult environment to live in. This is a psychiatric hospital in Khartoum, the one and only. Khartoum has Sudan has roughly 40 million people and 23 psychiatrists and about 5 psychologists. So you see they don't have a lot of resources. This is a case of Richard. Catatonia. So this is a young woman with her mother, and who was in a stupor, and this is a condition that we see occasionally in the U.S., but is commonly seen in other parts of the world, and can diagnose without taking a history. If you lift their arm up in the air, it'll stay there. This so-called waxy flexibility or catalepsy. So these are the kinds of situations they have. It's, I think one of the important lessons for us is the role of family in taking care of patients. And that's a big, big issue. In every hospital you go to, there's patient and usually their extended family. So, they may have 12 patients in a room and there's 6 relatives with each patient in many countries. This is a mosque in the desert of Sudan. It's about a 4-hour drive out of Khartoum. And this is a very, very famous mental health center in the Sudan, and it's run by Sufi religious leaders, Sufi sheiks. And the person on the right is one of these sheiks, and the person on the left is a good friend of mine, Dr. Ali Bilal, who was trained in Khartoum in the UK and now practices in Khartoum and is at the all-women's medical school there. And one of the things that happened as a result of my visit there was that his medical school decided to actually include psychiatry, not only in the coursework, but also to develop a clinical rotation. So, one of the things that can happen in low-income and middle-income countries is a little input can go a long way and dramatic changes can be affected. This is the hospital. And this hospital basically, as in much of the Sudan, really incorporates religion into treatment. So the patients here basically come with a family member. They live here for months and years. They work a cotton farm along the Nile. It's sort of a communal living style. They cook together, they eat together, all the patients, all the staff, if you will, the Sufi sheikh. And in addition, they also use very religious methods for treating these patients. And so, one of the things is to write about evil spirits and actually burn the paper with gum arabic in it and have the patient inhale it. And so it's really very much an integration of religious practices, traditional Sufi religious practices, with modern medication. And so I'm just going to end on a note about the future and a transition to Dr. Simone's talk about the how now, and to talk about the power of the cell phone, because I think, I'm not the expert on this, but I think that not only the technology, but use integration with the cell phone and computers really has the potential for changing the way we practice medicine, not only in high-income countries, such as the US, but in low and middle income countries. And I'm just going to cite a few things. So I'm going to cite a personal example, and that is my son, who lives in LA, developed a rash But rather than seeing his doctor, he whipped out his cell phone and took a photo of it, sent it to his primary care doc along with an email with his symptoms, and the doctor emailed him back and called in a prescription for him. So he didn't have to wait 1 or 2 weeks to get an appointment. He didn't have to take 3 or 4 hours off from work to go sit in the waiting room and be seen, and there was no bill. So they were both in LA, but my son could have been in Uganda and done the same thing potentially. And so it really has that kind of power. Some folks at UC Berkeley in the Citrus group have developed a microscope that goes on a cell phone, and it goes over the lens of the camera, and you can take a picture of a microscope on of a slide of a pathogen or a blood smear or whatever, and you can, if you have cell phone coverage, you can send it anywhere in the world. Isn't that amazing? It's amazing to me. And this, I put this up. This is, by the way, free. I'm not pushing anything here. But this is Medibabble, which is an iPhone application where you can take a medical history in whatever language is up there, Spanish, Mandarin, Cantonese, was that Russian, wasn't it? Russian and Haitian Creole, and they're working on others. This was developed by 2 medical students at UCSF where I am. It does have psychiatric questions, but when I queried them, clearly they could use a little improvement. But if you think about it, you could take, and these are all basically yes or no questions, and it's asked verbally. It's not read, it's asked verbally. Patient can either say yes or no, or point up or point down. And you can take a medical history, and the questions are asked by a native speaker. And if you think about it, you could do this in any country in the world if you have the right language, or you could do this in the US in an emergency room or a psych ward or what have you. And it just goes to show what new technology can do in the hands of the young. So with that, I will stop. Thank you very much.
Thank you, Dr. Van Dyke, for that great talk. We'll have, if you have questions, again, if you would move to the mic. While people might be moving, I have a question of my own I could throw out here. So you had mentioned the importance of having this interaction between, say, the higher income and then the middle, lower income communities in terms of promoting mental health. So what do you think the most important lesson that the higher income countries can take from the lower middle income countries?
Well, I think the, one of the issues is how do we deliver mental health care in the world? Because if you take the Sudan or what, there's never going to be enough time, enough money to train a professional mental health workforce. It's just not going to happen. And we have the same issue here in America because we have huge access problems in America. And so I think the big question is how do we deliver mental health services? And Dr. Simone is going to talk about that, but it's going to have to be delivered either through primary care and or through paraprofessionals. Paraprofessionals obviously with a limited repertoire of what they do, but nevertheless delivered by them, supervised by a mental health professional, supervised by a primary care physician. And some of this work is being done here at Dr. Caton's work and Irrigan's work and Stephen Vinoy's work around collaborative care models. But I think figuring out how to do this, a lot of that is going to be done in low and middle income countries, not just here, because they have no choice.
Mm-hmm. Thank you.